you so much for joining us here at The Research Her, the show working to improve the health disparities for women of color, one topic at a time. I am Alicia. I'm here learning and growing with you as we research our way to well-being. We are here and we are happy. I received some great audio feedback from one of our sisters who wanted to learn about a topic. Here she is.
Hey, The Research Her, it's Ashley, and I recently listened to the podcast based on deodorant versus antiperspirant, and I found that very interesting that those two are actually different and alarming because I've been using Secret my entire life, which is an antiperspirant. But also, I would love for you to do an episode on bacterial vaginosis. I learned that African American women are 2 times more likely to receive that infection. So I would love for you to do some research on bacterial vaginosis to help me out and help others who suffer from it and how we can avoid it.
Ashley, our great sis, thank you so much for bringing up this topic. I got you. I got us. I am so happy you brought this up because now I got some goods for us. This conversation today is so juicy. It's just full of just treasures, okay? And I cannot wait for you to take it all in. So let me get to it. I had the honor of interviewing Dr. Ruthie Arumala, who is an obstetrician gynecologist at Texas Hugley Medical Associates in Mansfield, Texas. Dr. Arumala is a physician that provides individual comprehensive care to women with a range of OBGYN concerns. She began her college journey at the University of Maryland, College Park, where she double majored in cellular molecular biology and genetics and psychology. So she was working her butt off, okay? Because those 2 majors together, that's something else. Then she went ahead to Mercer University School of Medicine, where she received a Master of Public Health. And then went and got her Doctor of Osteopathic Medicine at Rowan University School of Osteopathic Medicine. Then she continued on to do a postgraduate residency training at Georgetown University, where she specialized in obstetrician gynecology. Dr. Arumala pursued this career because she was very interested in having a career path that provided excellent service to women that looked like her and experienced similar concerns as she does. And she is an advocate, a passionate advocate for women's health issues and other issues such as sexual assault and domestic violence. She is the host of the Pretty in Pink podcast, which is available on Apple Podcasts, Spotify, and SoundCloud. And it's pretty much a modern woman's guide to health. Okay, so now let's get into these gems that she dropped in this episode. We have a doctor in the house. I'm so excited to talk to you. Welcome to the show.
Thank you very much for having me. It is my absolute pleasure. Ever since the first day paths crossed on Instagram, I have been so excited about your podcast and the information that you put out and all the good work you are doing. Thank you so much. Lovely episodes every single time.
Thank you. So I want to start off the show with a few icebreaker questions. So I want to start off with, what is your go-to meal?
My go-to meal? Ooh, that's really interesting question, but my favorite meal is shrimp and grits. My go-to meal is probably shrimp and veggies because I'm trying to stay slim.
Okay. And talking about staying slim, what is one thing that you wish were calorie-free?
Oh my God, if ice cream was calorie-free, the world would be such a magical place.
Such a magical place, yes. And Oreos.
Yes.
And if you could break the law one time, what would you do?
I would actually free as many people that were locked up for marijuana trafficking, I would just basically run and like open the jail doors.
Okay. I like that one. That's a really good idea, actually. We should just do it. Okay. So, did you always know that you would become a doctor?
So I actually really thought that I was going to be a fashion designer. I have an older sister who has a fashion line. She was a fashion model. I wanted to be like her. She's a cousin that grew up like a sister to me. And then the next thought I had was I wanted to become a sex therapist, which is pretty much what I do now with other things. But I remember talking to my mom about it, and she's like, "Are you okay? You're African. What am I going to tell people in the village that you do?" So a good involvement, and I am a sex therapist with a different title right now.
Mm-hmm. So tell us a little bit about your undergrad experience. What did you major in?
So I attended the University of Maryland in College Park, Maryland. It was an amazing experience because, at that time, I think there were like over 30,000 undergrads. So you could find your niche. And I liked that because I came from a very small town in Maryland called Salisbury, Maryland. It's about 30 minutes from Ocean City. My undergraduate experience was just really, really full. I majored in cellular and molecular biology and genetics, and I finished my first degree in 2.5 years. But I was on a full scholarship, so my parents encouraged me to do a double degree. So I started psychology during what would have been considered my second semester of my junior year. And I was able to finish on time. So it was a really interesting experience for me. I would have done it differently, though. I would have studied dietetics in retrospect. So if I did dietetics or nutrition science, when I finished undergrad, I'm a nutritionist or a dietitian. I would have been completed. So when I talk to people that want to go into graduate school, law school, medical school, I usually encourage them to do something that is concrete because you have a job that sufficiently pays the bills.
Mm-hmm. Yeah, and you know a lot about graduate school experiences. So you got a master's before you went to medical school. So can you talk a little bit more about that transition from undergrad to your master's program? Was it something that was intentional, or was it more important to you to get a little bit of public health experience before going into medical school?
So I should back up and say that my mom is a physician, and so I was exposed to what medicine was at a very early age. And I was always told I was going to become a physician. I was told that by uncles, not my parents. My parents didn't care what I did, but uncles, aunts, like teachers. I was, ranked first in my high school class. So, of course, everybody was like, that's going to be our doctor, blah, blah, blah. So I was always told that, but I kind of rebelled in undergrad. I said, I don't want to be cliche, the Nigerian female doctor. There's a lot of us out here. So I wanted to go into public health because I knew I wanted to leave a mark. I didn't want to just pass through history and be forgotten. So that's why I thought public health would be the best way, because I wouldn't be working one-on-one with patients. I would be working on a macro level. I had no idea what I wanted to do with public health. I still don't know exactly what I want to do with public health, and that's okay to evolve over time. But that's kind of why I chose public health at that time. In addition, my mom was an internationally trained physician, so she was doing her residency at that time. So for people who don't know, if you receive your medical degree outside of the United States, no matter how long you've been practicing medicine, to get retrained. So she was getting her residency training in Georgia. So I decided to apply to the same school that she was in so I could go and leave for free, because I know to save money. So I wanted to go and stay with my mom, mooch off of my mom for free while I was still pursuing my education. So those were factors. I'm 33, so at that time, that was 2007. Social media wasn't really big. You had no idea what other people were doing. You had no influence. Like, I had no idea. I think that one of the greatest assets that social media does for people who are wise is that it allows you to see what other people are doing, and you can get inspired, motivated, or it can kind of shape your ideas. So I really didn't know what I wanted to do at that time, and I just kind of learned a lot of things. I did actually 2 masters at the same time. I did one in public health and one in health administration. I started the first one was 2 years, and the second one was 9 months. It was long distance learning, so I was going back and forth from Georgia to North Carolina. It was at UNC Chapel Hill. So it was a lot of work, but it really set me up through the process of my medical training, because those 2 degrees, while I don't use them on a day-to-day basis, they have opened doors for me that I don't think would have been open if I didn't have that kind of training. So, that's neither here nor there, but it's things to consider. And I will say my second master's was completely paid for by the Obama administration. So it wasn't like I was acquiring additional debt through this process.
And was that the one that was long distance or the one in Georgia?
The one that was long distance. So let me just kind of also say that one of the things that I did a lot was I was always searching for scholarships, ways to minimize the financial liability and risk as I went through my process of acquiring. I had a full scholarship undergrad. I had medical school scholarship, which is almost unheard of.
Absolutely unheard of. When you just said it, I'm thinking
yeah. And I had multiple offers. I mean, multiple schools gave me full scholarships. So anybody that wants to go into medical school, they're out there. If you are a high performer, you actually get additional reasons for people to want you in their programs, because they know, one, you're a high performer, so they pay you to go to school. So, reach for the stars, because you get paid to go to school.
So you're working on your master's, time to graduate. At what point did you say, hey, okay, you know what, I'm going to go ahead and go to medical school?
2 weeks into my MPH, I 100% knew I was going to go to medical school. And this is why. I was in a course about diseases. They started to discuss obesity, diabetes, hypertension. I am from a family that's actually pretty healthy, so I had absolutely no idea what hypertension really was, what diabetes really was. And as I read about the way that it affected a community, how it was an epidemic, what the prevalence was, what the incidence was, I felt that I was not an expert at all, and I did not know what the actual disease state was. And that bothered me. I thought that in order for me to be able to affect the type of change that I told you that I wanted to do, which was I wanted to leave a mark, I needed to be an expert in whatever I was doing. So 2 weeks into my master's program, I had this epiphany. At the same time, I'm not sure if it was the transition from Maryland or DC to Georgia, I had a huge acne outbreak. So I went to see a dermatologist, and interacting with this dermatologist, I was like, I want to do what he does. I actually went to medical school to become a dermatologist, not to become a physician, because I don't know, at some point it heavily influenced me. And that's a really big deal, right? Because a lot of people make their decisions based on role models that they see, which, as people that have kind of achieved, we actually have to be very cognizant of the fact that we heavily influence people's lives, whether we know it or not. So the kind of life that we live has to be reflective of a positive. So that was how I made that decision. It was, one, I wanted to become an expert, and two, I admired the level of expertise that this physician had, and I wanted to be just like this. He didn't look like me at all. He was a white male dermatologist, but I said I was going to be the female Black counterpart to this person.
Wow. And now you're thinking about dermatology, and why did you switch from wanting to be a dermatologist? What changed from you wanting to be a dermatologist to becoming an OBGYN?
So I think dermatology was really romanticized for me. I thought, okay, look, black skin, brown skin, skin of color is very different from other types of skin. So I did some research and I realized that there were many dermatologists that were black. And then I realized there were many that were female. So I was like, oh, this is a good niche for me. But I started romanticizing it. I was really obsessed with cosmetics and cosmetic medicine and aesthetics because I suffered from acne. I mean, there were times in my life where 90% of the skin on my face was acne. So I really it was really romanticized for me. But it's also, I don't know if people know this, but dermatology is one of the most difficult specialties to get into from medical school. There are 5 specialties that are very difficult to get into, and they all touch the face. So neurosurgery, ophthalmology, dermatology, plastic surgery, and ENT, they're the 5 most difficult specialties to get into.
What is ENT?
Ear, nose, and throat. So I actually got a little intimidated in the beginning. You know, everyone told me how hard I needed to work. And so I started doing that. I found someone to do salicylic acid research with. I was doing bench research. Before we started this podcast, we were discussing bench research. As you know, Alicia is a bench researcher. So I was doing some of that in Delaware. I was driving from medical school in New Jersey to Delaware to do research once a week. I was going to do pathology discussions with the pathology professor so I could learn dermatopathology. And I did that for 2.5 years. And then my brother passed away in medical school, and I decided that, okay, I really need to sit down and look at what I want to do with my life because he was 24 and he passed away. So, you know, I need to make sure that every moment of my life counts. So I went ahead and went into the process of going for a year off research program. And I went through University of Pennsylvania. I went to Botswana. I lived in Botswana for a year. I was doing research in dermatology initially. And as I was there, the research was very exotic because we were looking at HIV dermatosis. But I really thought about what is dermatology and what is the bread and butter of it. Dermatology is cancer prevention, acne, and eczema. So that didn't seem like something really exciting for me to do. Basically, they do a lot of total body exams looking for moles, asymmetry in different lesions. It didn't sound that exciting. Looking to find and looking at the hair and the pubic hair, it just didn't sound like the best use of my life. And at this point, as I told you, I was bereaved or I was grieving. So I was trying to find the best way to use my talent. So while I was in Botswana, I started going through all the rotations that I had done because I went between my 3rd and 4th year of medical school. So I'd already done like the basic rotations in medical school. And I kept going back to the fact that I loved using my hands. So OBGYN popped up because it has a very prominent surgical aspect of it. So I really sat down and thought about it. Then I went to do rotations with the medical students in Botswana. Mind you, I was teaching a course also. I was teaching a public health course at the University of Botswana. Imagine your instructor coming to rotate with you. But I did that because I wanted to know more if this was what I wanted to do. When I came back to the States, I did more rotations in dermatology and in OBGYN. And I was at Georgetown University, which is where I ended up doing my residency. And one day in the middle of the night when I was on call, I thought about it and I was like, you know what? There are lots of people that look like me, including fibroids, PCOS, infertility, dealing with women at the most vulnerable state. I am built for that. It just was like clicked. I am built for this. So I never applied to dermatology. I kind of actually put it as one of the biggest failures in my life because I did it more at that time. Now in retrospect it's different, but at that time I did fear of not achieving a very highly desired competitive position. So I talk about fear a lot because I have been plagued and paralyzed by fear of failure and fear of success. There are a lot of times where I would dummy myself down so that I didn't appear more intelligent than I was. And so, but that's how I came to the process of choosing OBGYN. And it is the best decision. It was kind of like I stumbled into the decision, but it's the best decision because as you can hear from the way I'm talking, I'm absolutely passionate about my job. And I don't see it as my job. My job never ends. Everything I do is related to empowering, uplifting, uplifting and encouraging women to have the health possibly can have.
Yes. So we had a request on what we should talk about today, and it is bacterial vaginosis. And I want you to talk a little bit about what is BV, and yeah, let's get into the topic.
So I was really excited when you said you wanted to talk about bacterial vaginosis because this is really in my wheel. It's probably the most common reason why I have walk-in patients, non-scheduled patients, because bacterial vaginosis is actually the most common vaginal infection. So it is a bacterial infection, and obviously there are other types of infections of the vagina, but this particularly is a bacterial infection. And it has actually really puzzled researchers and practitioners because we are not actually really sure what it is. We have a great guess. So it is a infection of, we call it a polymicrobial infection, meaning like there's a bunch of different types of microbes that could be an infection. And that's really interesting because the vagina is not sterile, meaning that it has its own bacteria that normally grow there. I call it the normal floral, like it's beautiful, but you have your own normal bacteria. And sometimes you can have something that occurs that causes that normal flora to be disrupted. And abnormal bacteria or bacteria that are very aggressive start to grow in your vagina. And that's when you have this thing we call, this group of diseases, I think it is, bacterial vaginosis. So if you break down, or BV, if you break down the word, vaginosis is an infection of the vagina and then the bacteria. So that's what it is. It affects a lot of women. And it could be asymptomatic, meaning like you don't have any symptoms and we just happen to find out that you had the infection maybe when you get a pap smear, when we're doing an exam of the vagina, we're able to figure out that you have bacterial vaginosis. And you can also have symptoms. The most common symptoms is vaginal discharge. Vaginitis in general can have irritation, burning, itchiness, and abnormal discharge. But the primary symptom of bacterial is abnormal discharge. The discharge is usually gray or green, and it usually has a foul odor or fishy odor.
So statistically, do you know how it impacts women of color?
Yeah, so I actually figured out the statistics from your request because I see it so often, but it's really not, in our training, we really don't discuss the epidemiology based on ethnicity and race. But the CDC, the most recent documentation was in 2015, that there's a disproportionate infection in women of color. So for white women, over the course of their lives, 23% of white women are going to experience bacterial vaginosis. Mexican women is about 30%, so it's slightly higher. But for African American women, it's 50%. So as with many other things, we have a disproportional distribution of a condition, and bacterial vaginosis is no exception.
Do we know what causes it?
Like I said, it's a puzzle. Let me talk about what won't cause it, and that a lot of people think. So toilet, hot tubs, pools, and bedding do not affect bacterial vaginosis as far as we understand. Some of the things that we think cause bacterial vaginosis is hygiene issues. So wiping from the back to the front, because the vagina has different flora than the intestines and the anus. And so common microbes that affect the vagina come from fecal matter. So if you're wiping from the back to the front, you're basically seeding or infecting the vagina with bacteria that it normally doesn't have. So that's one reason. Another is douching. So if you remember what I said before, normal bacteria grow in the vagina. And bacterial vaginosis is actually a disproportional infection of aggressive bacteria that don't normally live in the vagina. So if you insert a douche bag and you clean out the normal bacteria, there is now space for abnormal bacteria to grow. So that's why I scream on the rooftop, no douching. Other things that have been cited have included like wet, so not cleaning yourself to the point where your vagina and the vulva is dry, wearing underwear that doesn't have cotton that allows the vagina to breathe. I actually tell all my patients, when you're not on your period, to sleep without any underwear, to allow that hours of oxygen to get through to the vagina, because most of the bacteria that characterizes bacterial vaginosis are facultative anaerobes. So they don't actually like oxygen. So that's why I tell patients that. So other things, and this is where it gets really fuzzy. Bacterial vaginosis is not an STD. However, sex affects it. So why do I say it like that? Up to 20% of women who have never had anal or vaginal intercourse can have bacterial vaginosis, right? So they're complete virgins that can have bacterial vaginosis. And it's most likely because of the previous practices that I've discussed. But when you talk about, there are sexual practices that lead to bacterial vaginosis. Some of them include your male partner can be a reservoir. So if you keep having intercourse with the same person, you're going to keep getting reinfected. But it's not an STD, meaning like your partner doesn't need to be treated. And there has been multiple studies, and there's no efficacy to treating the partner to prevent bacterial vaginosis. The second is the practice of anal intercourse to vaginal intercourse. That's the same thing as back to front wiping, right? Because you have an insertion of something that's going to seed bacteria from the anus into the vagina. So those are the practices that we talk about. But then there is also a high of bacterial vaginosis in women that have sex with women. So what is that? That should be, right? And so some of the theories include, or strong theories include, the oral sex, the mouth being a reservoir for the bacteria that's now causing the infection. So those are all things that we think through. So when I have a patient that has especially recurrent bacterial vaginosis, and I should just say this, 30% of all women who have bacterial vaginosis will have a recurrence within 3 months. It's a 3 and 3 rule. So 30% of women who are treated for bacterial vaginosis will have a recurrence in 3 months. So it's not like, oh my God, the medication is not working. We know that many people are going to be reinfected or not clear the infection in the beginning because their practices haven't changed. So we can treat it, but your practices haven't really changed. So I always talk to my patients from a behavioral standpoint. So when they have a recurrence, we actually sit down and go through every practice and make sure that there are any of these practices that can cause them to continue to get reinfected or not to clear the infection completely in the beginning.
Yeah, I wonder if there were any studies that show that it's more likely for it to reoccur as a result to not taking all of your antibiotics, because I'm sure that a large percentage of that number are just from women who got to like pill whatever, like 5 and didn't go to pill, didn't finish the entire dosage. Because my understanding of not finishing even once it clears up, if you don't finish the pills, you're setting yourself up for not every single bacteria to have died. And now what's happening is they had the opportunity to reharvest.
You're very right in that sense. So let's actually talk, since we started doing this, let's take a step back and talk about like the treatment of bacterial vaginosis from a pharmaceutical standpoint. And I should say this, I am from the physician mindset, and I think a lot of the younger physicians are from a physician mindset that pharmaceuticals are not the only treatment and are not the all-encompassing treatment. If we just specifically talk about pharmaceuticals, 3 major ways that we treat bacterial vaginosis is 1, clindamycin, and clindamycin is not used as often because bacteria is very highly resistant to clindamycin, especially in the Northeast US. So I have actually never used clindamycin, but I do have colleagues that do. And then we can use Flagyl, which everybody knows, or metronidazole. That's useful. Let's just say that there are always, with the treatment of bacterial vaginosis, there's always a vaginal way and an oral way. So we can either use pills or we can inject creams and gels cells into the vagina. So those are always ways to treat any kind of vaginitis. So the last way is called sinectazole. And sinectazole is very new. I've actually never prescribed it because I've never been in a place that has it on the formulary, but it is actually granules that you put into yogurt, and you only 500 milligrams twice a day for 7 days. Sinectazole is a packet of granules that you put into pudding and you use it once. Very new. I think it was approved by the FDA in 2014 or 2017. Please don't quote me. I don't remember exactly, but it's pretty new. So hopefully that will be better adherence to treatment. But I have a lot of patients actually who will come and they will be very bothered by their symptoms. And they will say something like, it's Memorial Day, it's July 4th, it is Labor Day, it's Valentine's Day. I'm going to drink, so I don't want to take flagyl, because flagyl requires you to not drink because it interacts with the metabolism of alcohol. And so you can have disulfiram-like reactions, which is a difficulty in metabolizing alcohol when there's flagyl in your system. So you end up getting drunker faster and you end up having intractable vomiting or heavy vomiting. You get really, really sick. It's like being drunk. So a lot of patients actually, like let's say they get diagnosed on a Monday, they'll take like their 4 days and then it's the weekend and they know that they can't take the medication with alcohol and they want to enjoy their weekend. So they'll just stop because the symptoms are gone. So I agree with you a lot. We see that a lot. And in addition to what you said, it's not that we just don't clear every last bacteria. That is correct. But the bacteria that gets cleared on the latter part of your medication is actually the most aggressive bacteria. So what you're doing is setting yourself up for recurrent bacterial vaginosis, and we define that as having more than 4 bacterial vaginoses in a year, infections. You're setting yourself up for that, and it's going to be harder to clear it the second and the third and the fourth time. This time you now have antibiotic-resistant bacteria growing in your vagina. So I would tell patients, like, if you decide that you're not going to be able to do the full thing, wait till you can do the full treatment. Because, like I said, 80% of women who have bacterial vaginosis are asymptomatic. There are some consequences to not treating bacterial vaginosis, but weigh that with forming antibiotic resistance.
So what happens if you leave it untreated?
So whenever we talk about untreated bacterial vaginosis, we have to break it down into pregnant women and non-pregnant women. So for non-pregnant women, there's an increased risk of pelvic inflammatory disease. And this differs from vaginitis because it is now an ascending infection that the pelvic organs, including the uterus, the fallopian tubes, the ovaries, and the pelvis in general. And pelvic inflammatory disease can actually progress to tubal ovarian abscess, which is when the infection is unable to be cleared. So the body forms an abscess, and that can make you really, really, really sick, and you will need hospitalization and IV antibiotics to clear it. So it can just progress into a worse disease. However, there is no one study that shows that the treatment of bacterial vaginosis will prevent PID or pelvic inflammatory disease. So the opposite is not correct, but we have seen that people that have untreated bacterial vaginosis can tend to progress to pelvic inflammatory disease. Next, you have risk HIV and herpes type 2, which is the herpes that are the genital herpes infection. They see that as a concomitant disease with untreated bacterial vaginosis. The opposite is not appropriate to say. So if you treat bacterial vaginosis, doesn't mean that you're going to prevent HIV or herpes, but they see that patients that tend to have a higher risk of HIV and herpes, and that's hard to quantify, but we find it in the literature. For patients that are pregnant, the issue is an infection that leads to premature rupture of membranes, which will lead to preterm delivery, prematurity of the infant, and low birth weight. Low birth weight because if the baby is premature, they're probably going to be less than 2,500 grams or 2.5 kgs. That's what we consider low birth weight. So that's just a cascade of events of the infection. So we define bacterial vaginosis as, or asymptomatic or symptomatic bacterial vaginosis. We treat every pregnant woman with immediately. You don't come in contact with a lot of asymptomatic women who are just walking around with the infection and are not pregnant because they don't come in contact with their provider, right? Because they're not pregnant, they don't have regular visits, and they are just walking around with the infection. So,
and Is there any way of getting rid of it outside of using antibiotics? Is it a way for you to get rid of it with more of natural remedies?
So here it's really difficult to answer that really plainly, but let's just talk about what people have put out there as natural supplements. I have to always stress that I am a physician that uses evidence-based medicine, right? So there are lots of remedies that haven't been studied. They don't have any evidence backing them. That does not mean that they don't work. That just means that they don't have evidence to show that they work. And because I am someone who subscribes to evidence-based medicine, I have to speak from that standpoint. That does not mean I ignore other types of remedies. It's just where my expertise is. There are practitioners that use natural and don't use pharmaceuticals, and that's where their expertise is. But with that being said, there have been things like lactobacillus supplements, and I should back up and say lactobacillus is the most prominent type of microbe that is a part of the normal flora or normal bacteria that lives in the vagina. So the thought is that if you take pills that have lactobacillus in them, then reestablish your lactobacillus in your vagina. And that way, if there's no bacteria in your vagina, then you don't have room for this abnormal or quote unquote bad bacteria. Unfortunately, there has been no evidence through research that has shown a clear benefit. However, it hasn't shown harm either. If I have a patient that tells me, Dr. Arumala, I'm taking lactobacillus supplements, as long as they're not having any adverse reactions for themselves, I don't discourage it.
In your experience, do you have those same clients come back and have to get treated using antibiotics, or?
Oh, yes, they get treated with antibiotics most of the time. They still get treated with antibiotics because what people don't realize, this is my opinion now, my 100% Dr. Arumala's opinion, not based on any college backing me. This is just my anecdotal opinion. I think that natural remedies are really, really good for mild infections. They are very ineffective for serious infections. I think most of the time, serious infections need some addition. You can still use a non-harmful natural in conjunction. And that's what I do with my patients. I allow them to take the supplements that they know and are not harmful to them, but I still treat the infection and hope them taking these natural remedies, they don't end up getting a reoccurrence. And I have seen that many patients that take a lot of the natural remedies that I'm going to discuss, they tend to have a lower rate of reinfection, but that is in my experience and in my anecdotal evidence. So that needs to be studied further and sauced out. Maybe we should be doing of natural remedies and pharmaceutical treatment if it's a significant enough infection. So the second thing that people use is yogurt. I was able to find a study in India that was published in 2018. Unfortunately, it only had 36 women. Whenever you're looking at studies, you need to look at how many women were studied because a smaller sample size doesn't really show what really is going on in the population. But they were all diagnosed with BV, and we have diagnostic criteria as physicians called AMSL's criteria. I'm not going to go into details, but they were actually diagnosed using clinical criteria that's accepted across the world. And then they divided the women into women who drank yogurt. They also drank a placebo, so that tasted like yogurt. So it was blind to the people who were actually participating. And they found that the women who and they also treated them with lactose. They found that the women who drank the yogurt drink ended up having almost no reoccurrence. And the women that did not did. That's where I see the efficacy and the usefulness of natural remedies is helping with reestablishing good flora after you clear the infection. Other things are probiotics, adding garlic to your diet. And why is garlic important? Garlic is a natural antimicrobial, antibacterial. So increasing garlic there are people who actually eat garlic pills to help prevent and treat bacterial infections. I prefer these next two are actually solutions that people put in their vaginas. I don't really like solutions in the vagina, but we also put creams and gels, like I said, into the vagina. So here are them. I prefer one more than the other. And the first is Apple cider vinegar has a lot of benefits. A lot of people know from the craze that we're having with apple cider vinegar. But apple cider vinegar, diluting it down with water and using it to wash the vagina has been an ancient practice that has been used over time, especially in Eastern medicine. It has been shown to be efficacious when it comes to treating bacterial vaginosis. Another is tea tree oil. Tea tree oil antibacterial. I actually use 100% pure tea tree oil on a pad on my skin. My skin can take it on my face for anti-acne properties. So some people use it diluted in the vagina. I actually discourage a lot of people from doing that because I use it on my skin and I understand how much it stings and burns. So I don't see how that can be used in the vagina. But I'm sure people use it because it's a also.
And I'm assuming with the apple cider vinegar, it has something to do with the acidity, right? Because it's so acidic, it's just pretty much killing off the bacteria.
Exactly. And your vagina is acidic to begin with. It should be acidic. It should not be basic. So it's just helping create a situation where lactobacilli, which produces lactic acid, is going to be able to thrive there.
No basic vaginas. Got it.
Basic. We only do bomb vaginas over here.
Okay. So I appreciate you so much for your expertise. I am so honored to have had you on the show. And I want to know, do you have any additional message that you would want to leave with us?
So yeah, the additional message I want to leave is, if you think that you're having a vaginal infection, you're starting to have itchiness, burning, you have discharge, I actually encourage that you either walk in or see a provider as soon as possible. And the reason why is because sometimes you treat what you think it is. Like a lot of people think they know and they have a yeast infection. And so they start to treat it with over the counter. And I talk about this a lot. Over the counter medication is very accessible, especially in the US, for the treatment of yeast infections. However, I usually encourage patients to go to a provider because it might not be what you think it is. Or you can have more than one infection. There's no moratorium on how many infections the vagina can have at once. So let's say like you have an STD, it can actually present vaginitis and you treat it and it might relieve your symptoms so you don't know that you have other things. So that's why I encourage people to see a provider when they have those infections. And my other message, if I could scream it from the rooftop, is absolutely no douching. Please, no douching. Your vagina is self-cleaning. It has properties to maintain itself. You can certainly, and I encourage you, to certainly wash the vulva and the outside of the vagina, but not inside the vagina.
And I'm sorry, one last question because you're here about using soaps in Summer's Eves. Should you be using the soaps in the Summer's Eve down there?
So the number one thing that we preach is water only. I do think that some people prefer to use a mild soap. Just try to use something that's non-scented. So non-scented because many people have allergies that they don't know about, and it actually ends up complicating your vaginosis. Personally, I use, feminine wash. I use a non-scented feminine wash. I just feel cleaner that way. And I haven't had any problems with bacterial vaginosis or recurrence with bacterial vaginosis. But I think that that's a patient-to-patient issue. I think that if you're having problems, you should go back and stick to water and a washcloth and eliminate it that way. Try to make sure that you're using very mild soaps, especially when you're washing your underwear. And go there, like peel back, eliminate, and see what is causing your issue. Because it might not be what you think it is. So, I also have started, transitioning into talking tampons and panty liners and pads because, like I said, there's lots of things in substances that we use that complicate women that have vaginitis or vaginosis. So those are all things to consider when you're someone who suffers from recurrent bacterial vaginismus. Not just the one-time one, but when you start to have recurrence and you're having difficulty. And before I go, oh my goodness, before I go, there's one thing I have to talk about: boric acid. Boric acid has been a savior for a lot of my patients that have recurrence. I don't use it with the first time, but boric acid is also considered an alternative treatment. It's 600 milligrams tablets put into the vagina. Please talk to your provider before you use it, but it has savor for a lot of people. I've had friends who've talked to me about bacterial vaginosis and the recurrence and how they struggle with it, and we talk about boric acid. They talk to their provider, they get the boric acid, and poof, they don't have it anymore. So I cannot end this podcast without discussing boric acid and its amazing results for people who have complicated or bacterial vaginosis. And with bacterial vaginosis, there are times you have to be on extended antibiotic treatment, but those become really complex and have to be designed individually by your provider.
Thank you so much for all of the gems that you dropped and all of the information and sharing your brain with us.
It is my pleasure, like I said, and hopefully we'll have you on the Pretty in Pink podcast soon, talking about your journey, especially your travel abroad. And I'm so proud of you doing, like I said, moving the envelope, getting new information. Guys, research is for a specific, special type of person. And so we're very, very proud of you, Dr. Franklin.
Oh, thank you. Premature, but we're on our way. Dr. Franklin in the making. Thank you so much for tuning in to this episode. If you want to hear more from Dr. Arumala, please go subscribe to her podcast. Matter of fact, go subscribe right now. It's called the Pretty in Pink podcast. You can reach her on Instagram at i.m.dr.arumala. And that will also be in the show notes, so you can just go ahead and click below. If you want more from me, I am at The Research Her on the socials, all of the socials. And please go download the new app. It is available on Google Play and on Apple's App Store. So thank you so much, and I'll talk to you next week. I holla.